My name is Cindy Anabel Garzón Lavalle, and I'm going to talking about cabozantinib in patients with advanced and progressing hepatocellular carcinoma. Definition: hepatocellular carcinoma, a cancer arising from the liver cells hepatocytes, liver damage manifested by cirrhosis scarring, is a primary risk factor for liver cancer. Cirrhosis may be caused by viral hepatitis, primarily hepatitis B and C, alkalosis, hemochromatosis, certain autoimmune disease of the liver, and other disease that results in chronic inflammation of the liver. Symptoms include abdominal pain or tenderness, jaundice in large abdomen, easy bruising or bleeding. Hepatocellular carcinoma is a cancer that starts in the liver. Hepatocellular carcinoma that accounts for most the liver cancers. This type of cancer occurs more often in men than women. It's usually diagnosed in people aged 50 or older. Hepatocellular carcinoma is not the same as metastatic liver cancer, which start in another organ, such as the breast or colon, and spreads to the liver.
The liver is the largest organ inside the body and is located just below the ribs on the right side. The liver has many functions. It filters waste and other harmful materials from the blood. It produces enzymes and bile that help with digestion. And it produces chemicals and hormones necessary for regulating many body functions. Liver cells are called hepatocytes. Liver cancer is classified as either primary, starting in the liver, or secondary, spreading to the liver from cancer in another part of the body. Hepatocellular carcinoma is the most common form of primary liver cancer. It develops in the liver cells and damages other healthy liver cells. Continuous growth of cancerous hepatocytes can cause malignant or cancerous tumors to form. In its early stages, liver cancer does not produce many symptoms and is hard to detect. As the cancer grows, symptoms such as abdominal pain and bloating, weight loss, nausea, vomiting, fatigue, and jaundice or yellowing of the skin and eyes may appear. While doctors do not know exactly what causes liver cancer, chronic liver infections, such as viral hepatitis B and C and cirrhosis of the liver, can increase a person's risk for developing the disease. Men are more likely to develop liver cancer, as are people over the age of 60. There are different treatment options available depending on the type and stage of the cancer. Surgery or a liver transplant are options only if the tumor is small and contained within the liver. If the tumor is very large or has spread beyond the liver, chemotherapy or radiation may relieve symptoms and prolong life, but this is not a cure.
Applications in medicine. Cabozantinib inhibits tyrosine kinase, included vascular endothelial growth factor receptor 1, 2, and 3, MET and ASL, which are implicated in the progression of hepatocellular carcinoma and the development of resistance to sorafenib, the standard initial treatment for advanced disease. The FDA has accepted a supplemental new drug application (SNDA) for cabozantinib as a treatment for patients with previously treated advanced hepatocellular carcinoma (HCC). Cabozantinib is used to treat advanced renal cell carcinoma (RCC), a type of cancer that begins in the cells of the kidneys. Cabozantinib is in a class of medication called kinase inhibitor. It works by blocking the action of an abnormal protein that signals cancer cells to multiply. This helps slow or stop the spread of cancer cells. Cabozantinib is also available as a capsule commetript to treat a certain type of thyroid cancer.
In the treatment arm, in the cabozantinib arm. This is very important because now we have two drugs. Both have shown positive data in second line. This is very interesting because we now have potential for multiple strategies and multiple options. It will be very important to understand, of course, the best strategy for each patient. But definitely, we now have plans in place for patients with advanced HCC, even for those who progress after first-line therapy.
The importance of the Cabozantinib trial relies on the fact that the three drugs that are in the field so far, that are sorafenib, regorafenib, and lenvatinib, are quite, in lingo of FDA, quite dirty molecules. They are very promiscuous. They are targeting 40 kinases or so. And the cabozantinib, despite that it's targeting several kinases, is more selective. It's blocking BAGF, c-MET, and AXL. So this is relevant in the sense that we know that BAGF is an important pro-angiogenic factor and pro-proliferative in HCC. c-MET signaling is also important. It's activated in 50% of the tumors at advanced stage. And then the fact that with this drug that has a more narrow spectrum of targets is also achieving clinical relevant outcomes, it is important in my mind. The results of the trial were, in summary, that the drug is able to expand survival around 2 months, from 8 months to 10.2 months in second line in patients progressing to sorafenib, without any remarkable adverse events, the usual hypertension, hand-foot skin, and so on, but nothing that is not manageable. And the objective response by RECIST was 4%, with a no bad modified RECIST has not been reported. But I think that it's another additional drug effective that is certainly needed for all these patients.
Pros. It interferes with the growth of cancer cells. Cabozantinib is used to treat advanced kidney cancer or thyroid cancer that has spread to other parts of the body. The multikinase inhibitor cabozantinib Cabometyx remains to be the sole oral drug to meet three clinical trial endpoints of progression-free survival (PFS), overall survival (OS), and overall response rate (ORR) in patients with advanced renal cell carcinoma (RCC).
Cabozantinib and tivantinib have been reported at ASCO 2012 to show an improvement in outcome. Specifically, cabozantinib has shown a quite impressive improvement in outcome in second-line setting with a median survival of 15.1 months. And the tivantinib story kind of evolved around two items. Number one, for the first time, we have seen that c-MET expression as a prognostic factor, where the c-MET positive patients will do worse than the c-MET negative. But interesting enough, when you come to treatment, the c-MET positive patients given tivantinib, they doubled survival compared to the placebo from about 3.8 months to about 7 plus. So clearly there's plenty going on in that regard. I think I would not be surprised. This not necessarily has been officially announced, but I wouldn't be surprised that two drugs will move into phase 3 trials in the second line setting, and we'll see where this will take us. One of the critical elements would you consider these to be evaluated as part of a enriched population of c-MET positive only versus just all comers. I would say probably there will be a quite intelligent discussion that will continue going on in the academic world, because on one part, yes, this does make sense from the tivantinib story as I mentioned it, but on the other hand, these are multikinase inhibitors and you don't want to undermine the other effects that they might have. And frankly, as we know, even c-MET expression is not being validated so far to know exactly what does it mean. So I think directions will differ, and some might take the c-MET enriched approach and others might take general comers.
Cons. Cabozantinib cosmetics may cause side effects. Tell your doctor if any of these symptoms are severe or do not go away. Constipation, nausea, vomiting, change inability to taste food, redness, splitting sores, or pain in your mouth, loss of appetite, weight loss, extreme tiredness or weakness. Pale skin, dry skin, rash, redness, pain, splitting, or blistering on the palms or the soles, muscle spasms, pain in joints, arms or legs, voice change or hardness, slowing wound healing.
There are two basic side effects. One is a fatigue. Some people call it mental fogginess. And the other is an intestinal nausea, vomiting, diarrhea, constipation side effect. We didn't usually talk about constipation as being a drug side effect, but many of the patients complain about constipation alternating with diarrhea, which is an unusual side effect. And then there are the other side effects that are similar to the VEGF inhibiting side effects. They include a hoarse voice, skin changes, ulcers on the fingers and toes, sometimes on the heels, and then a serious and on very rare occasions fatal side effects, which include blood vessel damage, one of which could include intestinal perforation, because the small blood vessels feeding the intestines can die, and you basically get a heart attack of the small bowel. There have been a few reports of heart attacks as well.
Issued a plea in Ecuador. The hepatocellular carcinoma HCC is the third type of cancer with more mortality in the world. Its prevalence varies being higher in Asia than in the West. The establishment of the pathology in a cirrhosis liver has decreased in frequency. Methods. Retrospective cohort cross-prevalence study with male patients who were histologically diagnosed with HCC between 2009, 2013, and Hospital de Solca, Guayaquil. A total of 67 male patients with HCC were analyzed with an average 64, 6, 31, 86 years old. The 43% of patients original from Guayas, 32.8% Laurels, and 41.8% only studied elementary school. The associated variables were cirrhotic status, 56.7%, the infections due to hepatotropic virus, 32.8%, and insulin resistant, 46.3%. The most important risk factor combination between DM plus obesity, 20.9%, and HBV plus cirrhosis, 19.4%. The first being exclusively from the no-cirrhotic group. Conclusion. I think that among patients with previously treated with advanced hepatocellular carcinoma, treatment with cabozantinib results in lower overall survival and progression-free survival than placebo. The rate of high-grade adverse events in the cabozantinib groups was approximately twice that observed in the placebo group. Cabozantinib represents a new treatment option for patients with advanced hepatocellular carcinoma after prior systemic anti-cancer therapy.
The trial, as you can see, was positive, as already mentioned, and it showed a median overall survival of 10.2 months for the cabozantinib arm versus 8 months for the placebo arm, which was, as I mentioned, with the p-value of 0.0049 and the hazard ratio close to 0.7, and if anything, this was clinically and statistically significant. In addition to this, the progression-free survival did improve it bypassed the 5 month for the cabozantinib arm, was only 1.9 months for the placebo arm, and again was clinically and statistically significant. Nicely, also, the response rate was improved. Understandably, TKIs are rather not expected to have major tumor shrinkage, but nonetheless, we had 4% a response based on RECIST 1.1 compared to 0.4% for the placebo arm, and again, this was statistically significant. If we look specifically at the patient who received only sorafenib prior to the therapy, interestingly, the median survival expanded even up to 11.3 months in that specific cohort. The drug was rather very well tolerated. The median dose was ultimately about 35, 36 milligram, and understandably, there were patients with grade 3 and 4, but it was exactly what we expect for that therapy, including the hand-foot syndrome, the hypertension, the fatigue, the anemia, and the elevated AST.